Okay, so pediatric content is on the NPTE. We don't know how many questions you're going to get. It's not that detailed in the content outline. However, when you look at the content outline for every system, the description says across the lifespan. Most questions are going to be in the neuro section, okay? However, of course, there can be pediatric questions in musculoskeletal or cardiopulm, as well as others. Are the previous recordings online? Yes. Using the same slides, or are they updated with each new round? I do update, but sometimes the updates are minor. So it just depends. I was just reviewing my PowerPoint about an hour ago, and the only thing I changed was something at the very, very end. So yeah, if you've already listened to this one on YouTube, and you have the slides, it probably is going to be pretty much the same. Okay, so, and by the way, anytime you have a question, put it in chat. All right, so there will be PEDS questions in musculoskeletal, cardiopulm, as well as others, but most are going to be in neuro. And tonight, we're really assessing your foundational knowledge related to primitive reflexes, but then we're going to see if you can apply your knowledge, because you need to be able to do that on the exam. Okay, and remember, primitive reflexes aren't only seen in the pediatric population, right? We can see it with an adult who's had a head trauma or something like that. Okay, so we're going to use the chat feature. So, oh, okay. So I thought we were going to our first question, but not yet. So what do you need to know for the NPTE? They're going to say, you know, you're trying to elicit this primitive reflex. How would you do it? Okay, so how do you examine it? They're going to say, you tested a primitive reflex and you found this. And you're going to have to say, well, is that what I was expecting? Was that the reflex? Is it not? Does it seem to be starting to integrate? They might ask you when the reflexes are supposed to be gone or integrated. They're never really gone. But when have they lessened to the point that you really can't produce them? Probably more what you're going to see is, how is this reflex going to interfere with your therapy, with their function, and how are you going to change your intervention to deal with this persistent primitive reflex? Okay. All right, so here we go. What's the name of this reflex? We're going to start our easy. So go ahead and put it in the chat. Sorry, I'm trying to manage, trying to get everybody muted. Yeah, plantar grafts. Okay, very good. All right, I'm gonna get the hang of it here in a minute. All right, yes. So what's the stimulus? I'm giving a pressure to the bottom of the foot, and this is my son, and he is, oh, I'm sorry. I saw plantar grafts and I thought that's what we were doing. Okay, no, watch again, sorry. All right, I gotta get myself together here. I'm doing a little noxious stim. Yes. Okay. So I did see a plantar grasp right at the very beginning. So yes, you're right. Right. Let's see it again. You were right. So right here, plantar grasp right there. And then flexor withdrawal. So it's both. Okay, good. All right, let's talk about the flexor withdrawal. So noxious stim to the bottom of the foot, we get flexion of the knee, hip, and ankle dorsiflexion of the ankle. It's integrated early, within the first couple months, okay? So here's your stop and think. If it does not go away, if the reflex persists, what is it going to interfere with? So just stop and think for a minute. What is that going to interfere with? All right, it's going to interfere with standing balance, gait, especially if they're walking on uneven surfaces. What if they step on gravel, right? And they have that strong flexor withdrawal. They're going to lose their balance. They're going to have difficulty with walking. They can get hypersensitivity to stimuli on the sole of their feet, can lead to toe walking, can lead to abnormal gait patterns, okay? So how would you adapt your PT treatment? Well, I would avoid walking barefoot, and I would tell the parents that that's probably not what they should be doing right now. You might need to have an assisted device, so if they do lose their balance, they don't fall over. If their balance is, if it's really affecting their balance, do they need a helmet to protect themselves? Educate the caregivers about walking surfaces, shoe wear, safety, appropriate gait, while the child is up and walking. Okay. What is this reflex? I'm going to do a stimuli on this right leg and it flexes, but the other leg extends and adducts. What is this reflex? So a lot of people say it's a flexor withdraw because I do a noxious stim on the right and the right leg flexes. That is a flexor withdraw. The difference here is the left leg is also going to extend and adduct. Anybody know the name of this one? Yes, cross extensor reflex. Good. So the way I remember it is, yes, it's like a flexor withdraw, but on the other side, I'm going to cross to the other side, and that other leg is going to extend and adduct. So it's a crossed extension reflex. Okay. So again, it's the same way to elicit it. We do that noxious stim on the bottom of the foot. It's going to look like a flexor withdraw on the ipsilateral side, but on the contralateral side, we're going to have knee and hip extension and adduction of the hip. Again, this one integrates early. We want it to go away. Okay, why? What will it interfere with? Well, it's kind of the same as a flexor withdraw. So it's going to interfere with standing balance, gait. Anytime anytime you're going to elicit that, get a noxious stim in the bottom of the foot, they're going to do this. Now, we think we have this reflex because it's a way to keep us upright. So if we do step on something that's sharp and we have that flexor withdraw, the other leg extends and adducts to keep us upright. We think that's why we have it. All right. Same thing with intervention, right? So we're going to avoid walking barefoot, use assisted device. Do they need a helmet? Educate. Okay, all of those types of things. All right, let's look at the next one. Okay, how do you elicit the positive support or supporting reflex? So put something in the chat. So if I said to you, you're evaluating a child and you want to evaluate the positive supporting or support reflex, in what position would you start the child in? What would you say? What position would you put them in? Or how would you elicit it? Anybody know that one? If not, that's okay. That's why we're here, right? Yeah, bring their feet to the floor. Oh, with a question mark. Very good. Yeah, basically we're standing them up. So you stand them up on the balls of their feet on a firm surface. And what happens is they will extend their legs to support some weight. And this does obviously become voluntary, and a lot of infants do it just voluntary, but really early, 1 to 2 months, it's more of a reflex. Okay, so this is a primary standing or supporting reflex or reaction. So what will it interfere with if it persists? So boy, every time that baby stands up, they extend their legs to put weight on their legs. It sounds like it might be a good thing, but what do you think it might interfere with? Yeah, walking. Yeah, walking. Or what happens when they want to sit down? Because their legs are extended, right? And it's going to interfere with their ability to then perform gait, right? All right, so yeah, it's going to again interfere with standing balance, gait, movement of the lower extremities, especially the flexion of the lower extremities because they're in extended area. Any upright motor skill is probably going to be an issue. It also can cause plantar flexion contractures because they tend to stand on their toes. Obviously, for them now to bend their knees to sit down or squat, they're going to struggle. If they do walk, If they can figure out how to walk, they have a very rigid, stiff-legged, not very much flexion, up on their toes type of a gait, okay? So how are you gonna change your intervention? Do you need an assistive device? Is there a balance issue? Educate. Monitor for those plantar flexion contractures. Do they need an orthotic? Do they need stretching? Do they need taping? Work on flexion and standing. Work on weight shifting and see if they can disassociate legs. Do something not in weight bearing that helps with the movement of their legs. Okay, and then hopefully we'll see this integrate as time goes on. All right, what is this one? Anybody know what that one is? I'll play it again. Yes, gallant, very good, gallant. Isn't that baby cute? This, my son would be horrified. This is my 24-year-old son. So he's in a lot of these videos, but he would be horrified. Mom, but yes, such a cute little baby. It's the gallant. So as you saw in prone, I was stroking the paraspinals on one side. And what happens is you get that ipsilateral lateral flexion of the spine. It's almost like they're trying to get away from it. This integrates again early at about 3 months. Okay. What will this interfere with? Now think about it. Every time something strokes my paraspinals, I might do that. What will it interfere with, or what could it end up causing? Think about that. Anybody have like what's going to be the problem here potentially? And it's not going to be just elicited in prone. I'm testing it in prone, but it can be elicited in sitting or standing. Yes, it can cause a scoliosis. It can cause a scoliosis. If they have a really strong on one side, it can start to cause issues if they're always going to that one side. What else function-wise? What do you think? It can go if I'm sitting, right? So what happens if I'm sitting and one side of my back gets stroked? Even clothing sometimes can elicit it if they have a really strong one. They're going to fall over. It's going to affect sitting balance. Okay. So sitting balance, it might affect their ability to crawl and creep on hands and knees. Gait, it can lead to scoliosis. A lot of these kids have issues with fidgeting, inability to sit still. They can also have issues with concentration. They have hypersensitivity of wearing clothes because they don't like the clothes brushing on the back of them. It's bothering them. Okay. So how are you going to adapt? Well, again, we're going to educate the caregivers. We're going to think about what kind of clothing we put on them. We're going to just work on all these functional things. We're going to work on that sitting balance. We're going to work on the crawling, creeping, and everything. We're going to monitor for scoliosis. If we start to see a C curve or whatever, we need to get other team members involved. Again, we're hoping this goes away. We're hoping, all of them get integrated, but for sure. All right, what is this one? He wasn't happy here with me, but. Anyway, this has got a couple different names, but you guys know what this one's called? Sorry, every time I go to open the chat, the video stops. So get a little bit better at doing it here. Yeah, it's a stepping reflex. Yeah, very good. Look how robotic he walks. Okay. So again, the stimulus is putting weight on their feet and leaning them a little bit forward. And look how high stepping and robotic that walking looks. Okay. So, yeah, you hold them upright, you lean them forward, you see that high stepping, robotic, kind of regular rhythm type of looking walking. And you're going to look at that and say, okay, that's not voluntary walking. I mean, first of all, they're too young to be walking, but that's just really reflexive type of walking. So it's called a stepping reflex, primary walking reflex, dancing reflex. Right? What's it going to interfere with? Well, standing balance and walking volitionally, right? Any upright motor skills. How are you going to change your intervention? Again, educate caregivers. Do you need an assist device? Do they need handheld ambulation? Are they at high risk for falls? I'm going to work on balance as much as possible. I'm going to work on upright skills. Maybe if they don't lean so far forward, maybe they won't elicit it, right? I treated a boy who was probably 12. He still had this, like, a really strong one. He could not walk by himself. He always had to walk with handheld assistance. He also had seizures. So he really couldn't walk with an assisted device, because if he had a seizure, which he had often, he was going to go down. And so his mom just always did handheld walking with him. And, you know, he was 12. I mean, we were hoping it would go away, and that's what his walking looked like. He was this high stepping, robotic kind of rhythmic type of walking. Okay. Name the reflex. What reflex would present with overall flexion of the body if you laid them prone, but overall extension if you laid them supine? What is that reflex? I put them in supine, they go in overall extension. So their legs and their arms go in extension. And their back too, really. And if I lay them on their stomach, their arms and their legs flex, and their spine flexes. Yes, it's the tonic labyrinthian. It does sound like STNR, but STNR, the legs and the arms do two totally different things. Tonic labyrinthian is everything goes into flexion or everything goes into extension. Okay, so that's the classic tonic labyrinthian. Good. All right, so not everybody has this. Okay, you won't see it in all babies. We hope that if they have it, it goes away by 5 months. This is what I'm jumping ahead to tell you what it interferes with. But think about it. If I put them on the mat table and they have this, and it is a little bit related with their head too, because as their head extends, their whole body extends. And when you lay somebody supine, right, their head kind of falls back and they're supine and they're going to go into full extension. Then when I put them in prone, their head kind of flexes, right? And their whole body's going to flex up. Okay. So, again, sometimes people say, well, it's the prone and supine position. Others say, well, it's also, you know, the neck, because the neck's flexing or extending. And this is what's going on. What is this going to interfere with? Think about that. What is this going to interfere with? What skills? A ton of skills they are not going to be able to do, because if it's a strong reflex, they cannot get out of that position. Yeah, rolling. How are they going to roll? If they're prone and they're in a little ball, they can't push up, they can't roll. If they're supine and they're in full extension and they can't get flexion, they're not going to be able to roll. Sitting, potentially. Again, if it's really related to the prone and supine position, no. But I think, again, if it's more within the neck, you can see it. So if they're sitting up and their neck flexes, they're going to go into overall flexion. If it extends, they're going to go over all extension. So yeah, crawling, creeping, bed mobility in general. Yes, very good. So let's see. It's going to affect anti-gravity control of developing mobility, prone propping, prone pivoting, rolling, belly crawling, creeping, transitioning into sit. They can't even, and somebody just said bed mobility. Yeah, if they're laying in bed and they're in extension, they can't even roll to sit up on the edge of the bed. And so it's negatively going to affect their orientation of the head and their ability to control their postures. Okay, so what do we do? Well, we're going to think about the positions we're putting them in. If I want to work on rolling, maybe and they're in supine, maybe I don't let that head go into extension. You know, maybe I give them a little bit of flexion, which actually might start to flex them, and then maybe that'll help them roll, right? If they're in prone, maybe I help with some neck extension to get them to prone prop or something. Maybe I'm going to do things in different positions. Maybe I'm gonna do more in sitting or sideline or a different position. I might have to use those different positions to strengthen. I'm gonna, again, educate the caregivers, what they're seeing, why they're seeing it, monitor for that integration, hope it integrates. The good thing is that not all babies are gonna have this to begin with. Because if it really is strong and it persists, it's gonna cause all kinds of problems. Okay, what's this one? He's talking, so we don't need to hear him talk, but now there's two different things you could say here. There's two different things. So let's do it again. This one, he's actually dropping the head a little bit. Okay, you see the arms come out and then the arms come back down. All right, anybody know that one? What's this one? Okay, let's see. Startle, yes. Moro, yes. Not the parachute. Okay, we'll talk about the parachute. I don't even know if I have the parachute in here, but I think I do towards the end. We'll talk about it. So this is the Moro reflex. He is dropping that infant's head, which gives the infant the sensation of falling backwards. And so their arms fly out to try and help, which their arms don't help. And then as they settle down, their arms come back in. Okay. Now I will take startle too, because by dropping their head, he startled them, right? So let's take a look at it. The Moro is when you drop the head backwards, when they're in a reclined sitting position. I always tell my students, be ready to catch their head. I don't want their head to go into hyperextension. So I always put my hands under their head and I let go of their head, but my hand's still there ready to catch their head. But as soon as they feel like they're falling, you're going to see that abduction extension of both upper extremities, splaying of the fingers, followed by flexion, adduction of their arms as they bring their arms back into their chest. All right, what's this going to interfere with? Can interfere with some stuff for sure. What might this interfere with? It does not go away. Feeding. Yeah, they can have some feeding issues for sure. Yeah, if you're feeding them and they go into their, possible. Let's see what I got. Sitting balance. Let's say they're in sitting and they go to look up at something really quick. Their arms are going to fly out. Can happen in standing. They tend to have oversensitive or a lot of reactiveness to sensory stimuli. Supine to sit might be difficult because every time they're getting up, if their head falls back, they're going to fall back. Adults that have it may have difficulty with driving, playing sports, eating. You just said eating, drinking. If they go to drink something really quick, that neck extension is going to make their hands fly out, right? Thankfully, this, again, this usually integrates, but I did treat a 16-year-old who had a really strong Moro reflex and a really strong startle reflex. And we would be working on sitting balance, sitting on the floor. She was one of 6 kids. So we'd be working, and then her younger siblings got off the bus and ran in the house. And her startle reflex and her Moro reflex, and she would just fall backwards and couldn't catch herself. So she still had it. So what are we going to do to adapt? We're going to educate our caregivers, monitor for integration. Do they need a helmet? Are they at high risk for falling and hitting their head? Maybe when they're sitting, they need to be sitting up against a couch, or do they need to be sitting in different devices or whatever, and then sitting when they can be supervised and make sure that they can work on it, but when they fall, they're not going to hurt themselves. So the startle reflex, the only difference, I'm going to skip through this one, is the way they're elicited, but it's the same reaction. But the startle is going to be a loud noise, a sudden movement, a bright light, but you're going to see the same reaction, okay? But see, they can be laying flat on the bed and their head's not doing anything, but they hear a loud noise and their arms are going to splay out like that, okay? So we think of them as the same, and if this is all the same information pretty much. So we kind of think of them as the same because the response is the same, but how we elicit them is different. The only difference here as far as your treatment is avoid certain stimuli while you're working on things. If you can avoid that loud noise, the sudden movement, the toys with bright lights, then you won't elicit that startle reflex. And you can be working on whatever you're working on without this interfering at that particular time. All right, you guys ready? What's this one? My cute son again. That's my son, Mitchell. Okay. Yep. ATNR. Yep. ATNR. So let's watch it together before I go to the next slide. So notice when he turns his head to I have to think about it. He's turning his head right now to the left. So his left arm's extended, his right arm is flexed. Okay, so he's already in that position, but when he looks over there, yep. And then when he goes the other direction, he started to do it, but he started to, and I didn't go the whole way, but yep, that's what that is. It's asymmetrical. So remember this, it's asymmetrical because one arm is doing one thing and the other arm is doing the other. So it's not symmetrical. Both arms they're doing two different things. Also, I don't think you can see his legs very well, but a lot of times when a baby has this and they rotate their head and their arms move, their legs do the same. So I think you can kind of see here, his right arm is bent, his right leg is bent. His left arm is straight, and it looks like his left leg is straight, okay? So how do we elicit it? We rotate the head. We can do it actively or passively, okay? The arm on the face side will extend, the arm on the skull side will bend. I don't have a hard time remembering this, but one student told me, the way I don't get confused is I remember somebody with a bow and arrow, an archer, okay? Because that's exactly what they look like, okay? And that hand will make a fist on that side. So yeah, what is this going to interfere with? All kinds of stuff. But what do you got? What is this going to interfere with? Look at this baby supine in this picture. What is this baby really going to struggle with? And you can see the flexion and extension of his legs too. Yeah, rolling. Rolling, that baby is ready to roll to the left, and guess what? That arm's in the way. That arm is in the way. That is going to be very difficult. Midline function, absolutely. Absolutely. Okay, it interferes with so much. Prone propping. If they're trying to prop themselves and prone on their arms and they go to rotate their head, one arm's going to bend, the other one's going to straighten. They're going to have problems with rolling, belly crawling, creeping, anything where as soon as they turn their head, their arms flex or extend when we don't want them to, and we need them to use their arms, that's going to be a problem. Sitting balance, gait. This reflex will affect every single fine motor skill. If it does not integrate, it's going to affect every single fine motor skill. They don't have good hand-eye coordination. They have difficulty crossing midline. Think about this. If I give this baby, if I have their head in neutral and I give them a bottle and they're holding onto the bottle, and then they turn their head to look at mom, what happens? Their hands go apart, they drop the bottle. So anything bimanual is very difficult. If they have it strong to one side, then that could lead to torticollis, plagiocephaly, I mean, all kinds of problems. So how are we going to adapt? Well, we're going to refer to OT for fine motor. We're going to monitor for that torticollis and plagiocephaly. We're going to adjust the environment so they do turn their head to both sides. We're going to educate caregivers. We're going to work on not truck. I have truck there. Work on trunk strengthening for sitting. So they rely more on their trunk than having to rely on their arms. Because if they're relying on their arms and they go to turn their head, their arms are going to go. They can't really rely on their arms. So let's see if we can get a stronger trunk and help them learn to sit that way, so they don't have to rely on those arms. Again, this is going to interfere with so much. We hope it integrates. All right, this one's really easy. You guys don't even have to put this in chat, right? This is the palmar reflex. His reflex is so strong right now. He was only like maybe 2 months old, maybe not even, that I was struggling to get my finger in there, because babies' fingers can cause the palmar reflex. And sometimes that's why they're constantly fisted, and have their hands in a fist. So I was even struggling getting my finger in there. Okay, so let's take a look at it. So how do we elicit it? We do pressure to the palm of the hand. And the response is finger flexion. And they're going to grasp whatever's in their hand. So I remember when I was, my daughter was little and I went to the pediatrician. And the pediatrician was like, oh, look, Mom, she's grabbing my finger. I'm like, no, it's the palmar reflex. But he was trying to be nice and I was being snarky. But okay, what's it going to interfere with? Well, a lot, right? If they have a strong palmar reflex, they may always have their hands fisted, which means they don't have intentional grasp and release of objects. It is going to affect all their fine motor skills. What happens when they want to bear their weight on their open hands to do prone propping? That open hand gives them some balance. If now their hands are fisted, that's going to be a problem. One of my students, her little boy was born premature, and he learned to crawl and creep on fisted hands. So he struggled, and I think he was a little delayed because he couldn't open those hands to help him crawl because they were fisted. Imagine them trying to pull to stand at a couch and their hands are fisted, right? So it's just going to cause a lot of problems. So what are we going to do? Refer to OT. Maybe they need hand splinting. Maybe we need to do something to help them keep that hand open. Maybe we need to assist them to get those hands open as we're trying to work on other skills. You know, on all of these, I have educate caregivers, so monitor for integration. But they can move along the developmental sequence with the hands fisted for gross motor. That little boy that my student has, he did crawl. He is creeping. His hands are fisted. It's harder for him, but he can do it. But we want to make sure that no secondary impairments develop. Okay. All right, name this reflex. What reflex would cause flexion of the arms and extension of the legs when the neck is flexed? Yep. STNR. Yep, very good. Yep. So let's look at it. So if I flex their head, their elbows flex, their legs extend. If I extend their head, their elbows extend, their legs flex. Now, do you see how this one is symmetrical? Both arms are doing the same thing. Both legs are doing the same thing. Okay. Now, I struggled with this even as a new grad, working as a peds therapist. I'm like, okay, what does the head do with the arms? Like what? Okay. Hopefully this helps you on the exam. What I remember is whatever the neck does, the elbows do. So if I flex my neck, my elbows flex. If I extend my neck, my elbows extend. Whatever the neck does, your elbows are going to do. Your legs are going to do the opposite. Hopefully that will help you remember it. So I'm going to give you an example. I was treating a little boy and we were working on sitting on the floor. And he could never hold himself up with his arms. He was always crumbling over, you know, and I had the toy on the floor and trying to get him to push up on his arms. And he was always crumbling over. And I'm like, oh my gosh, his arms must be weak. I need to work on these triceps. So I would put him on the therapy ball and he'd be looking up at mom and he'd be going on the therapy ball and his arms would be straight. And it looked like he had great tricep strength. And it took me a while and then I'm like, oh my gosh, he has the STNR. When I'm sitting him on the floor and I put the toy between his legs, he has to look down at the toy. His elbows flex. That's why he can't sit up. But when I put him up on the therapy ball and he was looking up, his arms extended. So I was like, oh my gosh. All right. So if I really want to work on sitting with this child, where would I put their toy? I'm not going to put it on the floor between their legs, right? So I got a bench and started putting the toy up. So he had to look up at the toy. Guess what? All of a sudden he could sit. And I'm like, oh my gosh, I can't believe I did that. All right. So what's it going to interfere with? Everything. From propping, belly crawling, creeping, sitting, like that slump posture I just talked about, sit to stand, gait balance, gait, hand-eye coordination. If their legs are always and their arms are always doing the same thing, you know, based on their neck movement, they can't disassociate their arms or legs. Their arms and legs can't do two different things. It can lead to W sitting. So if you look right here, it can lead to them ending up W sitting. And we don't want that to happen. W sitting for a little bit's okay, but we don't want them sitting like that forever. How do we adapt? Well, recognize the reflex. That was my problem. I didn't recognize it at first. Educate the caregivers. Think about what's your goal. My goal was to teach him how to sit. And so I had to think about where my toy went. In another position, maybe I'm going to be working on prone reaching or, and so if I want him to be doing that, I got to be thinking about where am I putting the toys? How am I changing the environment? Where is his head? And what am I getting? Monitor for integration, monitor for proper development of the spine. So again, there can be some issues there. They may need special equipment. As they get older and if cognitively intact, they may actually be able to modulate their neck movements. Prevent the W sitting, have the parents fix the sitting, refer to OT probably. All right. We already talked about this one, but that's my plantar grass. Yep. Okay, so we saw that in the earlier one with the flexor withdrawal. Okay. So we're applying pressure to the sole, the foot, the distal to the metatarsal heads. We get that toe flexion. This is going to integrate hopefully right before they start cruising and walking. What's it going to interfere with? They can walk. I have seen kids with a strong plantar grasp stand up and cruise and walk, but it is not easy. Their balance isn't good. They're going to be delayed. It's going to cause other problems as we go. So how are we going to adapt? Hopefully, again, it goes away. They really struggle to get kids' shoes on. I don't know if you've ever done this with a little kid and you're trying to get their shoes on and their toes keep curling. Their toes keep curling. And you're like, stop curling your toes. So it may be difficult for them to get on and off shoes. We may have to get different shoes. We may actually want to get an FO or something. We want to give them proper footwear. So maybe when they're standing and walking, they have to have something on their feet. So we're not eliciting that. Barefoot, we're going to elicit that. Consider the walking surface. If we have something that's rough or bumpy, it's going to elicit that. And you know, yeah, they might need some orthotics or something. So we're gonna monitor that. All right, you guys know this one. This is with an adult, but it's normal in a child though. Okay. So you got this one. You guys know this one, right? It's normal in a baby. So that is our Babinski. Yeah, so we're going to firmly stroke the sole of the foot in a lateral to medial curve. We get great toe extension, the other toes splay. They can have this up to 2 years of age. Okay, so It could maybe affect standing balance, walking and running, usually not. But again, what the important thing to know here is this is normal with babies. Okay, as they get older, it should integrate. So what you don't want to do is make the mistake of evaluating a baby and saying, oh my gosh, they have a Babinski, something's wrong. There's some neurological thing wrong. No, it's typical, right? But if it doesn't go away, same stuff we just talked about with the plantar reflex. Okay, so let's take a look at, let's kind of wrap up this and then let's do 8 questions that are NPTE type questions. So are you still struggling with, I don't think the exam will ask you when they start. I really don't. I don't even know as a pediatric therapist when all of them start, because I know any newborn is should have almost all of them. And if I work in the NICU, I might know them, or I'm gonna have a developmental tool that's gonna help me. I think what they're gonna ask you is, when do they integrate? But here, I'm gonna make it easier for you. Most of them integrate between 3 and 6 months. So I think as long as you know the outliers, okay, there's these 3 that integrate early, there's this 3 that integrate late, you will be fine if they ask you when they, the integration of these, okay? We didn't talk about rooting and sucking and the gag reflex, because I don't think you're going to see that on the NPTE. That would be more for OT and speech, but of course those are primitive reflexes as well. Make sure that you do know your righting reactions and equilibrium and protection reactions. Somebody earlier said the parachute reaction, that's this bar picture over here. So if I take a baby and I take their head down towards the ground, they need to put both their hands out to kind of prevent them from falling. That's a parachute. I want to see that, because that's telling me that in sitting or in standing, if they go to fall, they're gonna put out their hands to try and protect themselves. I want to be able to see that, okay? All right, here we go. I'm gonna start the polling. We're gonna do 8. Now, the poll has 10 questions, but all we're gonna do is 8. So I'm gonna have you read this question, go and put in your answer in the poll. I'm gonna time it in about a minute. I'm gonna go to question 2, then 3, then 4. You're gonna answer all 8 in about 8 minutes. And then I'm gonna walk you through all the answers. All right, I'm gonna go to question number 2. That's not a good question. Which of the following would best describe this? Oh no, best describe this finding. Okay, that's okay. All right, question number 3. Okay, I think this one's pretty easy. So we're gonna go to question number 4. All right, I think this one's pretty easy too. Just to kind of spit back the knowledge one. So we're gonna go to question 5. Okay, let's go to question 6. All right, let's go to question 7. Okay, and let's do the last one, number 8, and then go ahead and submit your polling, okay? Here comes number 8. All right, go ahead and submit your poll. All right, let's see how we did on these 8 questions. I hope, I want you to think about, would you have known the answers before we went through all of it tonight? You may have, but hopefully you felt more confident and you gained something here that you were like, okay, yeah, now I can answer this question. All right, I'm gonna go ahead and end the poll, and I'll go ahead and share it with you guys. All right, so let's see, for question number 1, 64% of you said A, so let's take a look at it. All right, so yeah, very good. You're treating a child you're treating is having difficulty sitting independently. You decide this is due to primitive reflexes that have not integrated. Which of the following would be the most important to evaluate? So the symmetrical tonic neck reflex, again, I gave the example of when I was trying to teach a child to sit, and that was interfering. The gallant too, if it's something stroking their back, they're gonna do this lateral flexion and they're gonna lose their balance. Could the ATNR affect sitting balance? Yes. If they turn their head, one arm's going to bend, the other one's not. But the crossed extension, no. So the crossed extension is a weight-bearing reflex, right? Remember, it's similar to a flexor withdrawal. If they're sitting, unless I'm poking the bottom of their foot, that's not going to be an issue in sitting. Will the startle reflex be an issue in sitting? Yes. But will the Landau reflex be a sitting? No. Landau reflex is when I hold a child suspended and like prone and they're able to lift their head. So it doesn't have anything to do with sitting. The Moro reflex, will that affect sitting balance? Yes. Will the positive supported reflex, where I stand them up and they extend their legs? No, because we're not standing them up. We're working on sitting. Okay. So hopefully that makes sense. The best answer here, the thing that would be most important to evaluate, is going to be that STNR and that gallant. Stop me if you have questions, okay? And after we're done, if anybody wants to go back to any questions, we'll do that too. Number 2, when evaluating a child, you decide that they still possess a strong STNR. Which of the following would the best describe this finding? Yes, when they flex their neck, their arms or their elbows flex, their legs extend. So that was just the definition of it. So when they flex their neck, both arms extend, that would be, no, that wouldn't be the STNR. When they extend their neck, both arms flex, both legs extend. Right, so that's opposite of what should happen. And then the last one is when they're looking, they're rotating their head. That's not the symmetrical tonic neck reflex, right? We learned that that's the asymmetrical tonic neck reflex. All right, let's look at number 3. You are screening an infant using an outcome tool. You place them in prone. They curl up in the fetal position. What do you think's going on? Yeah, good. Most of you said tonic labyrinthian. So if I put them in that prone position, they're in prone, their neck flexed a little bit, and they go into that fetal position or overall flexion, that is that tonic labyrinthian. So good. Number 4, you think that the infant you're evaluating has a strong Moro reflex. What would you see, right? Yeah, you drop their head a little bit. Those arms are going to abduct, the fingers splay, and then they adduct back toward their chest. So yep, that's exactly right. Good, 93% of you guys got that right. All right. Which 2, this one's a little harder. Which 2 primitive reflexes, if not integrated, will most interfere with the development of their fine motor skills? Asymmetrical tonic neck reflex. Remember, I said that will interfere with every single fine motor skill. They won't be able to do anything bimanual. They won't be able to cross midline. They have problems with hand-eye coordination. Huge problem. Palmar grasp. If I can't intentionally release and grasp things, that is going to be huge. Okay. The symmetrical tonic neck reflex, yeah, it's going to affect some of their fine motor skills, but if I can sit them up and keep their head in a neutral position, they could probably be able to do things. I guess you could say the same would be with asymmetrical, but any little bit of movement is going to cause an issue. So in the symmetrical, they might get some elbow flexion and extension, but it doesn't really affect their hands so much. So that one maybe not as much. All right, you guys got rid of C. And then D, the gallant, not so much, right? I mean, it would cause some lateral flexion of the trunk, but it's really not affecting their hands. So the thing that's most going to interfere is that answer A. That one's a little bit harder. Good, 86% of you got, guys, this one. Which primitive reflex is most going to interfere with the ability to belly crawl? Again, the cross extension would be if I was poking the bottom of the foot and one foot did a flexor withdrawal and the other one extended. It would affect crawling, but usually when they're crawling, nobody's poking at the bottom of their feet. Plantar grasp, nobody said that, right? Because they're not using their feet. They're gonna have a plantar grasp because that doesn't integrate till 9 months. And so it's a good thing that it doesn't really interfere. Parachute, we want them to have a parachute reaction. So if they're in sitting or standing and they go to fall, they put their arms out. But that's really, we want that. We don't want that to go away. It's definitely not going to interfere with anything. And it's not going to interfere with belly crawling. So nice job. This one, oops. Oh, I went too. I was trying to scroll on my, okay, this one I'm thinking, I don't know if I like this question. And I wrote it. So when teaching a child to ascend and descend the stairs, you would be most concerned about their safety if they still had which of the following? All right, positive tonic labyrinthian. We all got rid of that. That's really like prone and supine. It might be because there's a little bit of neck flexion. ATNR, it affects mostly the upper extremities, but it can do the lower extremities. If they're holding on to a railing, if they need to hold on to a railing, I don't know. I just don't see that one interfering as much. Again, a plantar grasp, that will interfere. But remember what I said, a lot of kids have a plantar grasp and can still walk and stuff. And if this kid's holding onto the rail, they'll be able to go up and down with that plantar grasp. If they have a strong startle reaction, that is a huge safety issue. So if they're walking down the steps, whether they're holding the rail or not, and they're startled, their arms are going to fly up, they're going to fall down the steps. So I think I just talked myself into liking this question, but it's one you really have to think about. It's one you really have to think about. I think I do like it now that I think that I talked it through. All right, last one. A child who's 3 months old typically cannot roll supine to prone. Which of the following is the most likely reason? So they have integrated the symmetrical tonic neck reflex. So usually that's not integrated till 5 months, 4 to 5 months. So that's not, that's really not usually the reason that they can't roll. They have a strong palmar grasp reflex. Usually they're still able to roll. They're really not using their hands when they're rolling supine to prone. They are still developing neck righting reactions. That's true, but when they're going supine to prone, really what they need, and why a lot of kids when they're that young can't do it, is they don't have the anti-gravity trunk flexion. They don't have good ab and trunk strength, so they cannot do that. They can't lift their head, contract their abs enough to start that rolling position. So, okay, you guys did great. You did really good on those. Okay, so there is information. If you did our course, our 2-day course, there's information about primitive reflexes in the neuro chapter. We have a new book, the 27th edition of our review and study guide. Awesome, awesome book. Highly recommend it. Think everybody who's studying for the exam should have it. There's a whole chapter on pediatrics. It's on chapter 9. And that's where we have the primitive reflexes. Also, you need to know the developmental sequence for the exam. And if you don't know, the CDC a couple of years ago updated the developmental sequence. We made sure that that is updated in the book. And again, here is my cute son, Mitchell, who is now 24 years of age, who would be just like, I cannot believe you're showing people this, but look how cute he is. His girlfriend would agree. He's awfully darn cute. There's my email if you need anything, if you have any questions. I do want to show you what's coming up. Next week is primary care differential diagnosis. I think that's going to be great. The next week, ECGs and heart arrhythmias. I might tune in for that one. Then we're gonna do low back. I'm gonna be back on the 27th doing pediatric neuropathologies. We have musculoskeletal disorders, ankle ligament, CPG, and then I will be back right before the test doing the GI system. All right. So have a good evening. I will stay on. If anybody wants to go over any questions or anything we already went over, or you just want to talk about anything, I'm going to hang out. But since it's 8:03, see ya. Hope to see you guys later. Hope this was helpful. And yeah, see you on another online office hours, hopefully. How can you have the course manual? We only sell it with the course. So if you take our 2-day course, you get the course manual. Yeah. And then the review and study guide you can buy online. And then we also have an app. If you want to buy the app, I think right now it's $40 and you get a lot of test questions through the app. And the 2-day course is offered in person, but also online. So if you go to the Therapy Ed website and you look up the courses that are being offered, you can see like where they are in relation to where you live, or which ones are online. You can join. Yeah, you just sign up for one of those courses. When will the recording be available? Oh, I do need to stop the recording. It should be available. Usually it's available tomorrow.